Hi, this is Brian Kim. I'm going to share with you case number 93 in the best way to do cataract surgery series. This is a fairly dense lens, and you're going to see systematic lens disassembly using double chop, cross chop mechanical fracturing techniques, using reduced amounts of ultrasonic energy. Instead of having to sculpt or impale the lens, I'm going to use my two instruments to fracture the lens by positioning the instruments around the lens material, crushing it into smaller and smaller pieces, and then using ultrasonic energy only when I'm ready to emulsify the lens piece. By doing it this way, I feel like it reduces the ultrasonic energy overall, as well as translating to clearer corneas after surgery. So I hold the eye with the cotton tip, and I use a corneal marker, which will help me to center and size a rhexis. And then I make my paracentesis incisions first on the right side and then the left side, making sure I'm parallel to the iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is some intracameral lidocaine, and then some dispersive viscoelastic. We use viscoelastic to coat the corneal endothelium and to inflate the anterior chamber and flatten the anterior capsule. This is the triplanar corneal incision, using the cannula to hold the eye steady, make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, and when I'm ready, I turn the eye towards me using the cannula, and then I enter. When I come out, I push some more dispersive viscoelastic to push the anterior capsule down some more, and then I go in with the forceps turned sideways, and then I'm going to start my puncture style rhexis. Go ahead and puncture the center, pull down towards me, grabbing the right side of the tear, and I'm being careful about grabbing it just right because I want to create the radius of the rhexis, which will help me align the rhexis to be the correct size and shape according to the previous corneal mark I made. I go around circumferentially, grabbing and re-grabbing, making sure my rhexis is about the right size and shape there. So I finish off the rhexis, burp some viscoelastic out, and this is the Capsulorhexis hydrodissection technique. I place a cannula under the rhexis edge contra-incisionally into the Capsulorhexis, point the tip down towards the nerve, get a nice wave, decompress on the left side, turn the tip to the right, point it down, and I'm able to spin the lens. Irrigate the surface of the cornea, adjusting my sleeve. Lift the incision with the chopper, going in with irrigation off to minimize Descemet's trauma. Removing the surface epinuclear material. By removing the surface epinuclear material, I can slide under the epinuclear ridge out to the contralateral fornix, pointing the phaco tip vertically subincisionally, bringing both instruments together and crushing the lens. That is the double chop, placing the chopper around the right heminucleus, pulling it centrally toward the phaco tip. That is the cross chop. Getting around the lens with a chopper and then using the phaco tip to lift the first quadrant up with some vacuum, and then crushing and dividing the lens into smaller pieces. And I do this instead of grabbing the lens with the phaco tip and then crushing it, which is really the standard phaco chop technique. I'm just sandwiching the lens pieces by crushing it into smaller pieces and then emulsifying the lens pieces when they're small enough. So that again is a modification of the standard chop techniques. So I get the chopper around the second quadrant, pulling it centrally towards the phaco tip, crushing it against the phaco tip. That's another cross chop maneuver there. And then sandwiching the lens pieces into smaller pieces and then emulsifying them. Just using the chopper to move that piece of that second quadrant, grabbing it with some vacuum, crushing it, and then emulsifying the lens pieces. Turning the second heminucleus in front of me, placing the chopper around the lens piece, pulling it centrally towards the phaco tip, which is positioned deep in the bag. By doing it that way, I'm very easily being able to separate the lens in half, placing the chopper around the third quadrant, pulling it centrally towards the phaco tip. That didn't quite work because the lens rotated when I did that, so I went back again, and then I was able to crush the lens in half there. Since I push down on the lens when I go across, this helps reduce the risk that I'm going to get around the actual anterior capsule and tear the capsule. But when you do that, sometimes and the lens is loose, it kind of rotates as you go out. So it makes it harder to get both instruments around the lens piece to chop it. And when that happens, you just go back again and repeat the maneuver. So again, I'm just sandwiching the lens pieces with the instruments, crushing them into smaller pieces, and then emulsifying the lens piece. And this is the last quadrant, placing the chopper around it, pulling it centrally towards the phaco tip, crushing it, and then doing the same maneuver, crushing the lens pieces between the chopper and the phaco tip. See, with the initial chops, you have to get the chopper out into the capsulorhexis when it's not loose, when it's still within the bag. And that's the primary maneuver for the cross chop. And so when you have the chopper in the capsular bag and pull it centrally toward the phaco tip, you can position that phaco tip deep and it divides it very effectively. Once the lens pieces are up and out of the bag, you don't really have to worry about placing the chopper into the capsulorhexis. You just simply manipulate the instrument so that they're around the girth of the lens and just crush it. And that's the thing, you have to get used to manipulating your instruments so that they're around the lens piece and then crushing it. So this two-handed technique does take some getting used to, but as long as you know how to position your instruments around the lens piece and then learn to crush it into smaller pieces, it's a really effective way to do that. One of the easiest things to do is to just use a little bit of vacuum to hold the lens piece, again, not using a lot of energy, but just to position it on your tip, and then you can crush it between the chopper and the phaco tip. So go ahead and remove the epinuclear material, which is pretty quick there. There's a little piece of lens material at the paracentesis incision. I'm gently trying to get it out. So I get it out, I take the chopper out. There's a little bit of piece there stuck in the incision. So I want to make sure I get that so it doesn't hide underneath the iris. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I start sub-incisionally removing the cortical material, sweeping side to side, getting some nice occlusion there. And when I do it that way, it's able to hold the lens and peel it off very effectively. Going around, removing the rest of the cortex, which tumbles out pretty easily there. Switch to polish mode, polishing under the rhexis edge. And this way I can be a little bit more confident when I sweep under the rhexis edge and I can't really see it. Again, if I grab Cortex, I'll hold it and then switch to Cortex mode, utilizing higher vacuum to remove it. Polish the posterior capsule surface as well. There's some fine material on the posterior capsule here that I'm trying to remove. Once I'm done with that, I'll go with the cannula, pushing BSS into subincisional capsular fornix. Filling the capsular bag with cohesive viscoelastic, and then sweeping underneath the rhexis edge. Inject a single piece acrylic intraocular lens into the capsular bag. The leading edge goes into the bag. As the lens unfolds, I quickly transition to the eye handpiece, activating irrigation, disengaging the haptics off the optic, going underneath the optic, tilting it and rotating it 90 degrees, removing all the viscoelastic from within the bag. Removing the viscoelastic from the anterior chamber as well. Switching to polish mode, polishing under the rhexis edge. Turning the haptics horizontally. Switching to visco mode, removing the viscoelastic, and then I'll hydrate the incision. So in this case, this patient was a little bit younger. I didn't think the zonules were an issue, so I used a single piece acrylic lens in this situation. So again, this is a fairly dense lens. You saw mechanical fracturing techniques, double chop, cross chop, carefully dismantling this lens. Again, when I'm chopping the lens into smaller pieces, I'm not utilizing any ultrasonic energy or vacuum when I do this. By using less amount of ultrasonic energy, I have found in my experience that these patients have much clearer corneas, even post-op day 1. Even with these dense lenses, my patients will have essentially no corneal edema. Having been a long-time horizontal chopping surgeon, I've always prided myself in disassembling the lens very effectively and efficiently. But again, with these dense lenses, I found myself utilizing a lot more ultrasonic energy. And I did notice that the corneal edema was actually more in those cases. I also noticed that I had a higher risk of rupturing the posterior capsule with those dense lenses. And really those issues are long gone with this technique. By using mechanical fracturing, double chop, cross chop, not utilizing ultrasonic energy with those maneuvers, using vacuum and ultrasonic energy primarily to emulsify the lens pieces in the central safe zone. This has really kept me out of trouble, and in my opinion, the best way to do cataract surgery. So I hope this was helpful to you, and I thank you for your attention.